I'm Dr. Carrie. I'm a medical oncologist. I specialize in breast cancer, medical oncology. I've been practicing out of the Van Alexander Cancer Center for about 15 years. And I wanted to talk to you today about some advances in personalized breast cancer management. In my last 15 years, I've been able to partake in a lot of advances in the way we treat breast cancer, and our treatment has really evolved. So the first thing I would say is that breast cancer is one word, but it's always personalized. So every person who is diagnosed with breast cancer has a personal story. And I think some of what I believe is personalized medicine is knowing your patient and knowing what treatments work for them and how that impacts their life. But the biology of cancer has also been very exciting because we are now dividing breast cancers into many different subtypes. Before I talk more about how we treat these different subtypes, I'll introduce you to them. We really subdivide breast cancer into about 4 different types, and we do this by looking at the biology. At first, when a breast cancer is diagnosed, the first thing that happens in the pathology lab is that the cancer is stained to look for several markers. 2 of them are hormonal markers, estrogen receptor and progesterone receptor. These are all part of normal breast tissue, so these are usually the lower grade, the slower growing breast cancers that have these receptors. There's a special marker on some breast cancers, about 30%, called a HER2/neu protein. It's a funny name, but it is a protein that is on about 30% of breast cancers. And this has really been the biggest success story in the treatment of breast cancer because this protein was usually a bad risk indicator. Patients who have this type of breast cancer in the past had advanced disease with even early stage or small tumors. Now we have targeted agents that has really revolutionized the way we treat HER2 positive breast cancer and has really turned this into one of the best prognosis breast cancer. And then lastly, the 4th category is a category we call triple negative breast cancer. And this is a breast cancer that doesn't have any of these markers on it. And we treat this breast cancer very differently now and are also seeing advances. So looking at those 4 subtypes of breast cancer, the first thing that's changed in my short time of practice, well, not that short, for 15 years, is that we treat a lot of the triple negative breast cancers and the HER2 positive breast cancers with medical therapies before surgery. This advance has made it ever more important to work closely with a medical oncologist as well as your breast surgical oncologist. When that collaboration happens, you usually are going to be getting the best, most advanced treatment. So when we see someone who has a more aggressive biology like HER2 positive or triple negative breast cancer, and as long as the tumor is not very small, we're usually treating those patients with therapy up front before surgery. There's a lot of advantages to this. One is that we can see the response of the tumor. There are many cases where the cancer completely melts away by the treatment that we are giving it, and then we know we are on the right track. We know prognosis is improved no matter where we started, and we know that we will be finished with therapy after surgery is completed. The other thing that is changing is that if someone doesn't have all of their cancer eradicated by the first treatment, we now can add additional treatment that improves overall and disease-free survival and helps us avoid that treatment in those who don't need that type of treatment. Also, in early treatment of estrogen-positive disease, I will say that we are probably doing a lot less chemotherapy than we used to. When we understood breast cancer as one disease, we understood that we had to give all the treatment we had against it. But now that we understand that some estrogen-positive tumors grow more slowly and respond very poorly to chemotherapy, we're able to avoid chemotherapy even in patients who previously had lymph node positivity and needed chemotherapy. We're able to do this because we are increasingly using genomic assays like Oncotype DX and MammaPrint. These are assays that look at the biology of the tumor. They look at 20 or 70 genes, and these genes are able to predict which patients can safely avoid chemotherapy and all of the side effects and toxicities that that entails. On the flip side of that, some women will have a high-risk estrogen-positive tumor, and we know when we give that woman chemotherapy that they will benefit greatly from it. and perhaps some of the risks and the trade-offs are worth it. So that's how I've seen practice of early breast cancer evolve in the last couple of years in my practice, and I think these are all really good advances. Unfortunately, some people will still end up with advanced disease, but there's a lot of advances there too. In my short career, I've seen tremendous change in women's ability to have a good quality of life with treatment and to turn their advanced cancer into more like a chronic disease that we have to keep treating. Another change that has happened is our treatment of advanced cancer. So in the past, when we treated advanced cancer, we had a certain number of medicines to use. In our first decision making, we would say, is the tumor estrogen positive? And if it was, we could give endocrine therapy, and then eventually we would move on to chemotherapy until treatment wasn't working anymore. In the last several years, there have been a lot of advances into non-chemotherapy regimens for estrogen-positive cancers. In my lifetime and in my career, I have seen lives change dramatically by the addition of these drugs. Some examples are the CD4K inhibitors. There's about 3 of them that we use commonly in practice. The one you might have known most about is Ibrance. And I've seen this medication change lives. I think people live longer and better with this medication that controls their disease and has very few side effects. In the setting of the more aggressive cancers, HER2 positive and triple negative cancer, we've also seen a lot of advances. In HER2 positive cancer, we have seen stage 4 patients who in the past would never have survived their cancer be cured of, or at least have prolonged survival with very well-tolerated therapy. As I mentioned, there's a lot of advanced drug combinations and targeted therapy for HER2-positive disease, and those medications are continuing to be developed, and we probably have about 4 new ones on the market in the last 2 years that have been improving quality of life and length of life. In the last setting, the triple-negative setting, we are seeing advances. There has been a lot of research in treatment of stage 4 triple-negative cancer because it has been challenging. However, in the last couple of years, we're starting to see some promise. There's the first immune therapy drug approved for triple-negative cancer, and for those who have certain markers on their cancer, this drug has given them prolonged survival and very good quality of life. And the advances in this field are only just beginning. So I just wanted to give that overview. I feel very fortunate to be able to take advantage of all of these new developments in personalized medicine, and I do think the future is very hopeful for even more advances. Thank you.